Hi, welcome to Level 3 Health and Social Care, Unit 307, Dementia. We're still in week 2 and we're looking at part 4 now, PowerPoint slides, our 4th set of PowerPoint slides. And we're looking at investigations for diagnosis and maybe thinking of some of the strengths and weaknesses of those investigations. So the objective that we're working towards with these sets of slides is criteria 2.1, compare and contrast the available investigations associated with the diagnosis of dementia. So you can't contrast everything because there's quite a lot. So I suggest you write a little bit, do a little bit of a comparison about where some are good and maybe where some are not so good. Okay. Um, so I'm going to go through quite a few of the investigations and then you can sort of think about which ones you're going to pick up for your compare and contrast. Okay, one of the first and most important investigations that is done, always done, is taking a history. This is usually done by the GP. If you're referred to a specialist, a more detailed history will be taken because this is not an emergent, feeling that you might have dementia isn't usually an emergency situation. It's not usually done in an ambulance or anything like stroke was in our last unit. So if you're starting to feel that some things are going wrong, the sort of the first thing you probably do is make an appointment with your GP. It helps that someone who knows you quite well maybe comes along with you as they can help describe any changes or problems that they may have noticed that you might not have as well. Or if you're starting to struggle with certain words, they can actually be a help in that direction as well. So the doctor will ask how and when symptoms started, what the symptoms are, how they're affecting your daily life. Ask about if you've got any other existing conditions, such as heart disease, stroke, or something, which could lead them towards maybe a diagnosis of vascular dementia. And if that's all being managed carefully, and they'll review any medicines, what else you're taking, etc. They'll get a general picture. Then you might start looking at some mental ability tests. And they normally use some quite standard tests to check people's memory and thinking. They're cognitive assessments, and they usually call it a general practitioner assessment of cognition, or GP cog, we often call it. Have you done a GP cog? So they would have a few tests that they can bring out. And though these tests don't immediately diagnose dementia, they can identify that yes, those memory problems are there, so we need to investigate further. And then they might put somebody on to a consultant who specializes in dementia. Most of them are just a little pen and paper test, and they have some of them are graphics, and some of them are just some short questions. And the sort of things they test is short and long-term memory. Can you remember what happened this morning? Can you remember what happened yesterday? What happened a year ago? Those sorts of questions. Concentration and attention span. They may ask you, or they may ask you to talk about something, and then they may put some time between it, and then come back to you later on and say, could you tell me what we were talking about? Those sorts of things. Reading, writing. Awareness of time and place to find out the orientation, like who's the prime minister, what's the date, when's your birthday, those sorts of things. Language and communication skills, just general conversation. They identify where they might be struggling for words. And it is important to remember that these test scores can be influenced by a person's level of education, so they are not foolproof. If someone who may achieve a high level at these things, they could still have dementia. It's just that they're very good at doing quizzes and questions and answers, or they may be educated to a very high standard. They might have a PhD or something. which means that their language and communication skills are generally better. There are people who may have not even learnt to read properly in the first place, so that's not necessarily a sign of their dementia, or they might be very dyslexic, and you wouldn't want to use that as a sign of dementia because they've had dyslexia maybe all their lives. So they need to be very aware of that. And so just seeing the answers on paper without knowing something about the person. So when they get passed on to somebody at the hospital, say, they can make decisions about their performance judging on that, when actually if the doctor had written this person's sort of reading level is very low, their spelling is a problem, they have dyslexia, or they actually can't make very complex conversation anyway. That needs to be accompanied it. Otherwise, on its own, it's not good enough. So remember that as a weakness of some of these mental ability tests. We've got the SAGE test. I'd like you to have a go at that. This is one of the most commonly used ones, and maybe you can see sort of what I'm getting at, really. So in extra reading, I'd like you can either stop now and go and do it and come back, or you can do it afterwards, after you've sort of worked through these PowerPoints. So have a look at the SAGE test. Have a go in your private time. There are 4 different tests. You can do any one of them if you like. They're all slightly different, but they all work just as well on the same areas. There is a score sheet and an explanation for the scoring, so you can see how the opinion gets developed. But what I would suggest is have a go at the test on your own first. Don't read the scoring sheet and the explanations till afterwards, after you've done the test. Be honest, be fair, do it yourself, and then you can see, what it's saying to you. And once you've done the test, have a little think about it. Think about what I just said about levels of education, maybe levels of language as well, and think about what could be the strengths and weaknesses of this test, because this is one of the most commonly used ones across the country, really, by GPs. Okay, so have a little look at it, and then you can decide why that might not represent things as well. Another one that's often used is what is known as the MMSE, the mini mental state, or mini cog. It's used, and very often this can be done by a nurse practitioner who, especially if they've got a dementia speciality or a psychiatric speciality, and they're quite used to using these. Or maybe if you go for a referral to the hospital, they'll do the mini cog or the MSCSE first. And it builds on the SAGE one, but it's got more detail, and it really tests skill levels in a different way. So the maximum MSE score, you can look up at MMSE if you want, you can find one. The score is 30 points. The score of 20 to 24 suggests mild dementia, 13 to 20 moderate, less than 12 severe. So you can see you can actually assess at what stage of the dementia it's on. So it's usually done after the first one when your GP thinks, yes, there is an issue, and they might send you on to the hospital or to a dementia unit for specialist assessment, and they'll do the MSSE. Okay. On average, the MSE score, a person with dementia, Alzheimer's, they decline about 2 to 4 points each year. So if on your first diagnosis you might have, say, 20 moderate dementia, they normally expect to see it go down a couple of points each year. So they will come back to the mini cog and do it over a period, of time, just to see. They can use this to see how your dementia is progressing. They do 2 particular tasks as well. That's the remember and repeat the names of 3 common objects. So they might do cat, hat, purse, and then they'll carry on talking to you, and then a few minutes later they'll say, can you remember the 3 things? And the other thing they'll do is a face of a clock, putting the numbers in the right place. Now, this may seem very, very simple, but actually it's something that gets clearly affected by dementia. And there are lots of different ways that can change, and it can help them with their diagnosis. It seems very simple, but if you go onto Google, you can Google Images, you can find lots of examples of people trying to do the clock face, and you can see how it's all changed around, and sometimes even the planes of it changed around. So that's worth a look as well. So the mini cog, which is done as with the MSE is questions, and the mini cog is these 2 little tasks. Okay, another thing we might look at is genetic testing. There are certain genes that increase the risk of developing Alzheimer's. There are some very rare deterministic genes. Now, for most people, genetics is not an issue. Okay, although there are some, and that we don't do routine genetic testing for Alzheimer's, but they do know there is a blood test for APOE4, which is the strongest gene for Alzheimer's. It's mainly used in clinical trials, but it's sort of picked up really. Carrying this gene mutation indicates it's a greater risk. It doesn't actually say you're going to get Alzheimer's, but it does say that you have a greater risk. So it might well have been picked up elsewhere. And there's lots of talk about it. What do you do if you start behaving as if you've got, that's the trouble. People just naturally assume they're going to have Alzheimer's and sort of give up a little bit early, really. But there is that one, so they say, there's also something called ADAD or familial Alzheimer's. It's a very rare form of Alzheimer's. It's about 1% of all Alzheimer's cases, but it runs very strongly in families, and it tends to begin earlier in life, sometimes as early as your 30s. Many of these people don't want to know, but some get tested to learn whether they eventually develop the disease, and they've used the ADAD families in clinical studies. So if you know that maybe one of your parents or their parents before them got very, very early onset Alzheimer's, there's a chance they could be an ADAD person. And then you may well be offered genetic testing if you think it's ADAD, because they can at least try to do, or they'll put them onto clinical trials or try to do early therapy with people. But some people just don't want to know, really, quite rightly. But I have added a fact sheet in extra reading for you to read about genetic testing in a bit more detail. But it is not one of the most common things we use on the NHS. If someone's private, they might choose to do it, but because it is so rare, we don't often go to it. If it's very early onset, they might do. Blood test. What they'll do, blood tests are really to rule out other things. It's a bit like with stroke. You'll do the blood test just to make sure that there might be some symptoms that we can exclude, which can be confused with dementia, and can be treated, and therefore find out that you haven't got dementia at all. In most cases, the sort of blood tests we do is liver, kidney, thyroid function, hemoglobin to check for diabetes, because people can be confused sometimes with untreated diabetes. Vitamin B12 and folate as iron levels can also leave people sort of confused and not functioning very well if they're and obviously if they need B12, then introducing B12 injections or tablets can usually right the wrong. So if your doctor thinks you might also have an infection, they might ask you to do some urine tests, because infections can cause confusion, bit disorientation, cognitive function being affected. So we want to rule all those things out. in the same way that we do in when we did in stroke as well. Then they might do a neurological examination. And they'll be looking for other things, really. They'll be looking to find out if you've had a stroke. It's not dementia, but you've had a stroke. If you've got Parkinson's disease, if you've got a brain tumour or some hydrocephalus through an infection, other conditions that can impair memory. So they'll test reflexes, coordination, muscle tone, eye movement, follow my finger, speech, sensation, hot and cold, pain. And if it doesn't indicate Alzheimer's, they might do some other tests because it might be another neurological condition, but not dementia. So really, that's the main point of a neurological examination is to find out what it isn't, in that sense, that it isn't to disprove dementia. As in stroke, brain scans, MRIs are often used for diagnosing dementia once all the simpler tests have been done, because we know that brain scans and MRI are expensive. So they wouldn't do them if they could, if with the paper test they have enough evidence to know there's dementia in a blood test. So like memory tests on their own, they can't diagnose dementia, but they're part of the wider assessment. If the earlier tests show that dementia is the diagnosis, then they won't do a brain scan. But if they've done some neurological tests and they think there could be something else, they will do a brain scan, especially if they want to prove it's a stroke or a tumour. The MRI scan can help confirm, though, because they can show the areas of damage. It can provide quite detailed information if you've got vascular dementia, because you can see the blood vessel damage or swollen blood vessels or clogged blood vessels. And it can show the frontal and temporal bone shrinkage if you've got frontotemporal, because the shrinkage starts to happen earlier with frontotemporal dementia. So it is quite useful in that respect. But as I said, we don't go to it if the paper tests make you, a 95% sure it's dementia. They probably wouldn't do a brain scan, mainly because of the cost. Other scans, CT scan, similar to a brain scan, not as detailed, doesn't show the structure of the brain very well. So in this case, it's probably not as good choice as an MRI. Other types of scan is a SPECT or a PET, and that's even more detailed. So they wouldn't really go to those unless the MRI did not give you enough information. Okay. So what I'd like you to do is to look at the different types of investigations that I've talked about. Remember, your SAGE quiz is in extra reading and your genetic fact sheet is in extra reading. Maybe do a little bit wider research on them and find out for each one of them a strength and a weakness. I've mentioned some strengths and weaknesses of why they get used. Remember, some of them won't give you a diagnosis of dementia, but they will give you a diagnosis of something else. So in that sense, it can be useful. If you've got a symptom of something else, they say, okay, there's more chance this person's had a stroke or a brain tumour or something like that. But then you still have to keep checking in case they happen to have dementia as well. That is the problem. So strengths and weaknesses of each type of investigation, and just think about how you're going to prepare and contrast them, because you'll only have so many words and you need to summarize. So you might have to put them into little chunks. But you probably, to do a compare and contrast, I want at least maybe 3 compares and contrasts. You don't have to do every single one, but certainly the paper scans you need to talk about, brain scans you probably need to talk about, and then maybe something else, blood tests or neurological, but at least 2 or 3 different areas you should be able to, even if you have to summarize them into quite sharp focus sentences. Okay, And remember, there needs to be a compare and contrast. So you can't just write and describe 3 of them. You've got to compare them about why maybe a sentence about maybe why one test might be more useful than another because it achieves more things, or why one test maybe isn't as good as another because it doesn't give you a full diagnosis. Okay, but you've got to give me something. Okay, so that's the end of these slides as well for this week. So as I said, have a look at in your extra reading, look at genetics and SAGE and read up a little bit more yourself. These are all easy to find out. Okay, thank you, and I'll see you following week.